There are major health disparities in the US, and race appears to be the driving factor. But when we control for other factors, particularly income, the situation becomes much more complex. I'm David Stern, president of Stern Consulting. Welcome to our presentation of Drivers of Health Status Disparities, an examination of variation using population-based surveys. Our subject is especially topical. What drives differences in our health? It's a complex question. Our genes, behavior, and socio-demographic status all presumably play a role in our well-being, not to mention the presence of an advanced medical system to intervene in what nature and nurture have provided. And how do we measure health? To shed more light on these questions, I'd like to introduce the two people primarily responsible for this study, Brian Williams and Janine Molino. Brian is the Director of Analytic Services at Stern Consulting, and Janine is a biostatistician and professor at Brown University. Brian, let's start with you. You were involved in the study design and analysis. Tell us a bit about those processes.
Thank you, David. We wanted to cast a broad net to capture what we suspected to be the determinants of health status. Those determinants may be broadly classified as socio-demographic, behavioral, and medical, and include factors such as age, sex, smoking status, and presence of chronic conditions. These suspected influences are the independent variables we selected for the study. And as you can see, this is a wide range of topics. To access all of them, we needed broad-based data sources. And having worked with a variety of data sets, we identified two as being particularly robust in providing what we needed. They are the National Health Interview Survey and the Medical Expenditure Panel Survey. Both of these are long-standing, population-based national surveys that address an extensive range of relevant topics. They also address health status in a number of interesting ways. We identified three areas for study: self-reported health, work days lost to illness or injury, and bed days. These measures have a synthesizing quality to them. They consider all of the underlying factors that influence well-being and result in an ultimate determination. I'm in good health, or I was sick enough that I stayed home from work, or I was in bed for 4 days. NHIS addresses all three of the measures. MEPS addresses self-reported health and work days lost. We decided to conduct separate regression analyses using each of these sources to enable a broader perspective for our study and allow us to compare the results. To highlight some of those results, I'd like to turn it over to Janine. Janine?
Thanks, Brian. For each of the two data sets and each of the three outcomes, we did a separate regression. We began by testing for interaction effects between race and income. And we did, in fact, find a statistically significant relationship between these variables for each of the three outcome measures. This confirms our earlier finding that the effect of race on health does vary based on income. So in our subsequent models, we stratified the regressions by income level. We also added a number of control variables to further ascertain what drives variation. The specific regression models and other considerations are addressed in the documents posted in our NAHDO virtual booth, along with the detailed results. For now, I'd like to summarize a few key takeaways. And here they are. In our unadjusted models, health status varies by race. There is an interaction effect between race and income, indicating that the effect of race on health differs across income levels. In our income stratified models, otherwise unadjusted, most racial groups tend to have worse health compared to non-Hispanic whites at all but the highest income levels. In the income stratified models adjusted for socio-demographics, behaviors, and medical conditions tend to drive differences in health outcomes, particularly at lower income levels. At higher income levels, socio-demographic factors become more prominent, although at this level, most are reporting good health. The population overall seems to be reporting very good health. This may be inconsistent with what we know about disease prevalence in the US and requires further investigation. So there are some of our highlights of our study. I look forward to discussing the results further with you throughout the conference.
Thank you, Janine, and thank you, Brian. And thanks to all of the NAHDO community for joining us. We hope you take the opportunity to view all of the related material in our virtual NAHDO booth and to join us at one of our Meet the Experts sessions scheduled throughout the conference.